So I'm going to record your neurological assessment. Okay, so some things we did in class last week, because your sensory and your neurological go together, as you'll see as we start talking, and we'll finish up neurological physical assessment in the lab next week. That's why I did these two following each other and then motor right after, because of the correlations. Okay, so your neurological assessment is broken up. I've broken it up for you. We will cover cranial nerves, then cerebral function, then motor function, sensory function, and reflexes. So on your cranial nerves, you have, this picture shows 10, 11, and 12 should be in there somewhere. Oh, I know why they're not in there. Okay, so you have 12 cranial nerves. You would have learned something in anatomy and physiology, some hopefully a mnemonic to help you learn them. I know the old mnemonic. I'm sure there's new ones out there. The one I learned is on old Olympus. On old Olympus towering tops, a Finn and German viewed some hops to get me through 1 through 12. I really like this picture because I think it helps you remember where they are. It shows 1 right over the nose, because that is your olfactory or your sense of smell. You might test that with something real foul or an alcohol wipe, or they might use coffee. We're not going to do that one, but you should know how to test for it. 2 is over the eyes, because that is your optic nerve. Your optic nerve is tested with visual acuity and visual fields. One way of testing visual acuity, as we did last week, and you'll do in the lab, is with the Snellen chart. And then your visual fields, where you're checking for peripheral vision. You might use the confrontation test to do that one. Then the next few go together. Number 3 is your oculomotor, that shows you above the eyebrows here. 4, your trochlear. And 6, we'll get back to 5. 6 is your abducens, and we'll say a little more about abducens. But 3, 4, and 6 all have to do with the movement around your eyes. So you have your oculomotor, right? Yes, oculomotor. So you have your pupillary response, which you do with the light, which we will practice in the lab, but we did discuss the PERLA, pupils equal, round, reactive to light and accommodation. So you shine the light from the side in, you watch the pupil constrict as the light hits it. You'll shine it in one eye and watch that constrict, and you also look to see that the pupil in the opposite eye is constricting also. Your accommodation is taking an object, usually your finger, having them look at it from a distance, and the pupils should dilate. And as you come closer, the pupils should constrict. If you pull it back out, they should dilate again. That is called accommodation. The other is your ELM, or your extraocular muscle movement, where you move the finger in that star movement. Mostly that is the cranial nerve 6 that you're testing there. Right here, your abducens. Another way to test the abducens is have them turn their eyes toward the temporal side. Ocular reflex is another one, but that's not something I'm going to teach you. That's more in-depth neurological at a later date. So we skipped over number 5, your trigeminal. And if you notice the 5 in the background here, there's the whole shape of the 5, because the 5, your trigeminal nerve, is your sensation in your forehead, your cheeks, and your chin. You might test that with a cotton ball, have them close their eyes and if they can feel the sensation in these places. The other thing is mastication. So over here on the side is their mastication muscle. So being able to chew, swallow with this muscle. You probably, if you later will learn more about trigeminal neuralgia. It's very painful, and they have painful nerve. It comes down here and onto your chin, and we'll talk more about that in class. Okay, we did abducens. 7 is your facial nerve. Looking for 7 in this picture. Here it is. 7. There's your 7 here, and your backward 7 over here. Your facial nerve, it's your facial muscles. So you'll have them do movements with a frown, smile, whistle, puffing cheeks. And you also could test it with taste on the anterior aspect of the tongue, which we won't do that one, but we will do the funny faces. Cranial nerve number 8 out here is your acoustic, and they have it over the ears because it is your hearing, also your balance. Your cranial nerve 9 down here, they have it like over the chin tongue area. That's your glossopharyngeal. You will test 9 and 10 together because the glossopharyngeal is number 9, number 10 is your vagus, and you test those with their ability to swallow, cough, the strength, quality of their voice, their gag reflex, and you look when they open their mouth to make sure they're symmetrical, bilateral together, symmetrical rise of the uvula, that it's not dragging on either side. You can also do the taste, which we're not going to do, on the posterior third of the tongue. I don't think number 11 is in here because that's your sensory accessory muscle or nerve that you see here. It's a muscle strength of the neck and shoulders. You can test that with them shrugging their shoulders and pushing up against you, which we'll practice. And hypoglossal, which is number 12, that's mobility and strength of the tongue. Oh, there's number 12, sitting right in there. Oh, goodness, here's number 11, sitting over the shoulders for your neck and shoulder muscles. And there's number 12, sitting there in tongue, because it's the mobility and strength of the tongue, position, atrophy, and fasciculation. Fasciculation is almost that little tremor of the tongue that when they try to move it. Okay, those are your cranial nerves. Okay, so when we get next to your cerebral function, behavior, level of consciousness, memory, general knowledge, thought process, and communication. There are other more in-depth things, but as a registered nurse, you will not have to go deeper. So how would you test behavior, evaluate behavior? You're looking at facial expression, posture, affect, and their grooming. Your level of consciousness, you might see that as LOC. That is your orientation to time, place, and person. You might document it as oriented ×3 or ×2. Your memory, you're testing their immediate, recent, and remote. So you might do not do recent, you might do the immediate. Give them a couple of numbers and ask them to repeat it back to you. Some remote or some recent or immediate could be what year is it? What day is it? Some remote might be what year were you born? General knowledge questions. Who is the president? How many days are in a week? Thought process. You're watching their attention span, their ability to focus, their responses to you, whether they're slow, can they process it? Is it a slow response? No response. Communication. How is their speech and language? Is it appropriate? Can they enunciate their words and their sounds with their muscle and nerve function? This is a Glasgow Coma scale. Should be familiar with it because you will use this scale and you add up points. You will learn it more in med-surg, but you add up points. So if they open their eyes spontaneously, like their eyes are open when you walk in or without any noise, they get 4 points. Verbal response oriented times 3, person, time, place. And motor response, they're able to follow what you say. 6 points, 5 points, it's 11, 15 points. So the best is right here. 15 points is a perfect Glasgow Coma scale score. Okay, now we get into motor function or cerebellar function, but just want you to know it as your motor function. I don't think NCLEX or Kaplan would ask for cerebellar, but anyway. So motor function, touch the thumb of each finger on the same hand. We'll practice that in class. And finger to nose test is also your motor function when it comes to a neurological assessment because it's cerebellar. So we will practice that also. More cerebellar is your gait and posture, heel toe, walk on toe, hop on one foot, and we can cover that more in lab and maybe in the classroom. So we do the sensory function. Light, touch, pain, and temperature, things you might do. The only way you can do a complete, accurate sensory function is if the person is alert and cooperative. Otherwise, it cannot be a true, complete sensory function test, which is logical, but keep that in mind. Always test sensory with the eyes closed, go side to side, and do systematically, like from different parts of the body and down. So light touch you might do with a cotton ball on the face, like we talked about with the cranial nerves. Pain, you could do a pinprick with something sharp. Sometimes I've broken a Q-tip or something and used that. Temperatures, not really tested much other than maybe you can try something cold because you're not going to really do something hot. Sometimes a piece of metal is cold. Discriminatory test, that's where I gave you 3 types of discriminatory. These are in your terminology at the end of this PowerPoint. So we did a little of this, talked about the vibration with the tuning fork. Stereognosis is being able to identify with the eyes closed, identify an object, a well-known object. This shows a picture with the key. I've used coin, maybe a marble, something that should be known, and they just feel it with their hand, stereognosis. And 2-point discrimination, I'm not sure if you can see it in this picture. This is something with 2 pricks, 2 ends on it. So can they distinguish close together that there are actually 2 distinct things hitting them? That is a sensory function test. 2-point discrimination. I threw this picture in on dermatones to help you understand. Coming off our spinal cord, our nerves, they travel and we have sensation go through the skin. So even though you may have an injury at one place, the dermatome reflects all these different areas for your sensory function. And this is something with atrophy or loss, steady loss on this neuron structure in the brain and spinal cord starts at age 65 and goes down. So they will start losing the sensory function due to the termitones losing their sensation. Okay, and the last one is reflexes. I will not test you on these. We will do some of them, probably just the patellar. Achilles I always have trouble with, but you should understand the main ones for your major deep tendon reflexes are your triceps, biceps, patellar, Achilles, and the next slide, which is your plantar reflex. As a registered nurse, rare that you would do it, you might do the patellar, but we can play with that, but you need to be familiar with what they are. Here's an image of the plantar reflex. This is one as an RN that you will do. I like this picture because it actually is the only one I found that shows that you go to the outer aspect and around here. Stroke the lateral aspect of the sole of the foot. Note movements of the toes. They should come in. Babinski, the toes curl in. You want to see a negative Babinski, plantar reflex with toes down. You want to document a negative Babinski. If you do this and the toes go out, that is a positive Babinski. That is a bad reflex and it's a neurological damage. It's different in infant, but you'll do that when you get to family nursing. Okay, so subjective data. What kind of things am I asking them?